we're done with diabetes. So again, let's move to number 2. Let me introduce again the anterior pituitary gland. That's number 2. Oh, please look at my screen. Nursing care management of clients with anterior pituitary gland disorders. That should be your number 2. And then I discussed under this what it means to have your hyperpituitarism with growth hormone excess. And that we said that the clinical condition is giantism, or what you call gigantism. Common in young people, like probably the age before 20, no? And acromegaly for the adults. Again, I told you that the endocrine problems are very visual. So this is a picture of somebody, of a lady, I think 15 years old from China, whose height is like, at a young age of 15, is already running like 8 feet, almost 8 feet. And then a picture of a lady with acromegaly. In the Philippines, we don't normally go through a lot of checks. We just accept it as a change, in the physical feature. But acromegaly is growth hormone excess, especially in the adults. There is a change in the appearance. Now, we went to a hypopituitarism where we have a growth deficit, hormone growth deficit. And we introduced the picture of what it means to have a dwarf. So it's very visual. It's simply failure to grow, but definitely they're fully human. Except for their small size, we keep on saying they are just simply like you and me. Well, people may call it because of genetics, but yeah, if we have had the adequate test, it should be also part of testing the growth hormone. It's a deficit. So, we in the Philippines, we're just accepting them as, genetics, or it runs in the family. There is some truth to it though, no? May truth man, tuod man. Okay. And
Doc,
then, okay.
excuse me,
Yeah.
Doc.
Yeah, I'm listening.
Ang last na topic was, ang nag-end was diabetic neuropathy, Doc.
That's correct. That's correct. That's why I'm starting now.
Ah,
That's why I'm now
okay.
here in number 2.
Okay,
Diba?
okay, Doc. Yes, Doc.
Oh, okay. That's why I'm now in number 2. Sige, Isaiah, thank you. So I'm now moving on to pituitary gland disorders. And number 2, I said number 1 is diabetes, no? Nursing care management of clients with diabetes. Now, number 2 is nursing care management of clients with anterior pituitary gland. And let me repeat again, the only hormone I will discuss is growth hormone excess. And the two clinical conditions, as I've said, is giantism or gigantism. Either way, they're acceptable for young people. That means below the age of 20. And for the adults, we call it acromegaly. And now I'm showing you pictures because, as I've said, appearance is affected in endocrine disorders. This is, as I've said, a 15-year-old lady in China with a height almost 8 feet. No, almost na siya sa wall, sa roofing. No? And acromegaly is for the adults, which is growth hormone excess affecting the appearance. But as I've said again, in the Philippines, we're not very conscious of testing. We just accept it that probably, well, she's old, well, she has matured, her features have changed. But if we could have had done proper testing, it will point to what we call acromegaly or growth hormone excess again. Now, here in the hypo, which is a growth hormone deficit, we talked about what it means to have, the dwarf And we said it's a failure to grow. It's very slow, but again, let me repeat, it's proportional growth, except for their small size. They appear completely normal. So let me, some of you will ask, will there be, something to manage? Well, probably replacement of hormones, but sometimes the hormone itself, particularly for growth hormone, may be a little more expensive. But together with some of us who discover that it's genetic, but when I ask, there could be no as short as them, but definitely the family has shorter height than 5 feet, no, than 5 feet. But ini silang duha yan na tamaan gid niya. Except for their small size, they appear completely normal. Okay? Sige. Let me move now to the number three. Number three in your outline, please, of disorders. We're now moving to nursing care management of clients with posterior pituitary gland disorders. And I told you to organize your notes. Please do not get lost. Hindi madula, ha? Please do not get lost. As I've said, it's pituitary gland disorders. See, let's introduce the pituitary gland. Oh, the posterior, as I've said, this is the entire pituitary gland. Listen now. We have the anterior portion, which is 80% and a bigger portion. The posterior portion is about 20% of the gland. So this is more colored. There's an anterior pituitary. We're now looking at the posterior. Now, the posterior pituitary gland secretes two very important hormones, one of which is oxytocin, which is only activated during pregnancy, delivery, and lactation, whose primary effect is for uterine muscle contraction and for the mammary glands. No? But let's look further into the other hormone, what is ADH, or your anti-diuretic hormone, whose target is the kidney tubules. Again, let me repeat, if it's a hormone, we should know the target. And these are the targets. So never accept a hormone if it doesn't have a target. So I think it's clear, no, with the color that we have, it's clear that the posterior pituitary gland is the smaller portion of the gland and has two important hormones. Sige. Let me introduce the disorders. Sige. You have what you call your syndrome of inappropriate ADH, popularly called SIADH. Now, what's the cause? Pareho na sa quiz kanina. What's the cause? It's always the hormone. And never forget that ADH is released in large amount. Can you imagine a hormone which is called antidiuretic, no? Whose target are the kidney tubules are released in large amount. Now, the other disorder is diabetes insipidus, and we will explain later why it's popularly called water diabetes. The diabetes we know is glucose or sugar, no? But now it's going to be water, no? That is. But the cause, listen carefully, is ADH deficiency. So you have a large amount, excess. This is the deficiency. Okay, be ready with your notes now so you can contrast the two disorders. Okay. With SIADH, the cause, as usual, do never forget when I talk of the cause, it's always what you call ADH is released in large amount, meaning excess. So if ADH is released in large amount, what will happen to the body? So the body keeps the fluid, no? So the body keeps the fluid. So the characteristic symptom of SIADH is fluid retention. And if you keep the fluid in your body, the picture will be that of edema. So I don't need to explain edema because we have discussed fluids and electrolytes in the first semester. But my concern is the urine. No, let's say, because it's called antidiuretic hormone. So listen carefully. Antidiuretic hormone, it affects the urine output. So open up for me, please, Kina, or probably Eliza Vita. What is your concept if the urine output is oliguria? Sige, go. Kina, Bernadette, and Isaiah, or Eliza Vita. Ay,
Dehydration, Doc.
urine output kita, urine output.
Decreased, Doc. Decreased urine output, Doc.
Okay, I heard you, Liza. Yeah, but I want you to know what's your concept of oliguria and what is anuria. Sige, go and answer me, Liza. Oh, wala na ha? Sige, go
Wait
Ang
lang,
Isaiah.
ano,
Doc.
ang anuria, Doc, it is if ang kidney wala siya ga produce urine, Doc, ang anuria.
Okay. Sige, ang oliguria
Um,
yun.
Oliguria, Doc, is when ang urine output is less than 400 ml per day, Doc.
Okay, sige. Okay, ready. I'd like you to know now. I am now teaching you nurses when you read and you take the licensure exam. When you talk about, urine output, will go by the amount. Ano kadamo, no? So don't say increase, decrease, or anuria. For some people, they would say absence. There is no such thing as absence of urine. So, okay, for the last time, let me clarify this. Ready? If in SIADH, when you say oliguria, some people call it scanty urine, scanty urine. But again, let me go back to our main concept. What's the normal urine output per hour? If most of you still remember, go.
30
Isa,
cc.
30 cc per hour. Okay. Multiply 30 with 24 hours per day. How much would that be? That's the normal urine output. Can somebody tell me?
720 cc per
Thank you.
hour.
Thank you, Kate. Thank you, Kate. So if you say scanty urine, you have to give the amount. Okay, so ready. An oliguria is a urine below 500 cc in 24 hours. So that's why it's called scanty below. Nga naman miss, pila ang normal. The normal is supposed to be approximately about 720 and more. Okay? So mahambal ka anuria, no such thing as absence. Pila bala ang amount. When you say anuria, okay, ready in your notes. When you say absence of urine is a urine output below 250 cc in 24 hours. Or in some books, they use 300, below 300 cc in 24 hours. That's too little. Huy, kajutay sang ihi. No wonder they call it anuria. So let's be more one step wiser this time. Where did the fluid go? The fluid is retained. Now, again, let me introduce if your urine output is considered, concentrated, that means the specific gravity is affected. Meaning, if it's concentrated, the gravity, ang kabugaton sa ihi, heavy. No, heavy ang ihi. So let's say the normal specific gravity is uh, zero point 0.6 to 1.5. 1.5, ready? When you say concentrated urine, that's above 1.5 in terms of gravity. Sige, let me go to DI or diabetes insipidus, popularly called water diabetes, and I'll explain along the way. ADH is deficient, kulang. So the characteristic symptom is fluid excretion. So sige ka lang, ihi nga ihi nga ihi. And if you lose more water, more water is lost. The clinical picture that the patient will manifest is dehydration. So your urine output is considered to be ihi, called polyuria. And that's why it's called diabetes, but you only have high water output. So what is the normal? Again, suliton ko, 30 cc per hour times 24 hours is about approximately 700 plus. Polyuria is a urine more than 800 cc or more in 24 hours. Some people even said 1 liter per day, more than 1000 cc is considered polyuria. So with ADH deficiency, your urine becomes diluted. And if you have to take a test called a urine specific gravity, your urine is diluted, meaning it's magaan, no? Magaan siya. So if the normal specific gravity of urine is zero point 0.6, then if it's diluted, it's below zero point 0.6. Sige. Why does this happen, Miss Chua? Why does an ADH problem happen? Ready? Why does an ADH problem happen? It's usually due to what you call a brain pathology. So let's look again at the picture of the pituitary gland. Listen carefully now for the last time, please, to look up palihog. The pituitary gland is a very tiny gland. Ang atong description at the base of the brain. That's the location, no? At the base. Siya base of the brain. So it's a very tiny gland at the base of the brain. So if you have a brain pathology, it could either be a brain tumor or new growth, what you call brain trauma brought about by vehicular accident, a fall or mauling, or the client has a brain vascular condition like either a stroke, a CVA, or hypertension, or the patient has brain infection like meningitis and encephalitis. Listen carefully. Any of these two conditions can happen. Suliton ko, any of these two conditions can happen, either SIADH or it could be your diabetes insipidus. In what I have, no, in what I sometimes witness, I go on duty with the previous, students in CLMMRH neuro ward neuro. Amo ni pirmi ang koso, vehicular accident, kag stroke, area, vehicular accident, kag stroke. And most of the patients suffer from SIADH. No, you get to wonder why are they having very little urine? What is happening? Wala gaihi. So, how to manage it? As usual, I've always taught you the administration, careful administration of your IVF or electrolytes. So don't forget that. And I have already taught you to monitor the five. O sige, open up ane kay iban o. Claire, open up Claire and Rolf. I know you don't have problems, Rolf, and DJ also doesn't have problems. Sab, you have good connectivity with Rain and Pauline. So open up for me. Wella also has good connectivity together with Hans. So can you please give me the five now that I have always taught you what to monitor and the five? Are you ready, Chloe? Chloe Ibanez, ready, go. Wala na, absinan tagit ni Karon. Sino man ready sini? Joey or Neil, Neb? Because I know, Ella, you have good connectivity in the States. So keep yourself open. No? So indeed, do not follow the others who are having struggle. So keep yourself open. Otherwise, you know, you're not just attending the class. Sige, who would answer me? The five, whoever listens to me. Claire, are you ready, Claire, to save the class? Claire,
Yes,
go.
yes.
Okay, ready. What's the
First,
five?
miss,
Monitor the
first you
five.
need to check the blood glucose level of the patient.
No, 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 no. The monitors of five, I taught you that was for
Have,
diabetes. But
yes,
first,
vital signs, miss, vital
thank you,
signs.
very good. Slowly lang. Five, vital signs. Sige, keep that again. Write that down for the last time. Sige, number two, go, Claire.
Monitor intake and output.
Very good, especially that we're monitoring the output, which is either scanty, oliguria, anuria, or polyuria. Number three, go, Claire.
Monitor level of consciousness, miss.
And GCS. Very good. Thank you, because we're talking of brain pathology. Very good. Brain pathology. Monitor the LOC and together with the GCS. Number four, Claire.
Monitor ABG, miss.
Thank you. You monitor laboratories like ABG and probably your blood glucose. Sige. And number five, which I want you to do is please observe for, any other complications. Sige. So you monitor the five because we're looking at, an imbalance in terms of your hormone. Thank you, Claire. Sige. I think that's it. No, so you already know the five. But again, I always go back to this. Why is this, Miss Chua? Because the tiny gland, which is the pituitary gland, is located in the base of the brain. So, any brain pathology, listen to me, listen and look at my screen, please. Any brain pathology, either an infection, either a tumor, a new growth, either a vascular problem or infection for that matter, will definitely affect the pituitary gland. Again, I've told you, I promised you, I don't know if this is the class that I promised, that I will go ahead and, invite to the class. I will invite to the class Catherine Jordan of 3B. She would want to share with you a case of a 9-year-old who had been suspected of a brain tumor, no, which had affected the pituitary gland hormones. So, but again, she has class, and I cannot pull her out from her class to join us for a few minutes. But one of this time, remind me because she has very beautiful case scenario and the tests, no, the hormone test done to the child, the 9-year-old girl, is made her understand what is facing. So one of this time, remind me to invite Kathy to the class. Okay, Rolf, Angela, also, you might need to remind me one of these days. Together with Section C, we will ask Kathy to share, what she had been through. Okay, thank you. From there, let me move now to one of the very important discussions that I have, which is Number four now. I'm now moving on to number four. So organize again. One, NCM, clients with diabetes. Two, NCM, anterior pituitary gland disorders. Three, NCM with posterior pituitary gland disorders. And number four, where I will spend so much time, please look at my screen, nursing care management of clients with thyroid gland disorders. So I'm now moving on to thyroid gland disorders. So I think we need to spend more time here, really. So let me introduce the thyroid gland first. Okay, ready? Location. Listen carefully. Location. The thyroid gland is located in the anterior portion of the neck. When I say anterior, sa tubang. And whenever you look at the person, it could be the thyroid gland, you're looking at it. Yeah, yeah. You know, it's the thyroid gland you are looking, the anterior portion of the neck. Okay, ready? It kama no, in front of the trachea. Sige. And trachea is lagyan sa hangin. So please look at my drawing very well. In front of the trachea and the larynx. And the larynx is your voice box. So please be careful. You've got to know your anatomy very well. Where is it located? In the anterior portion of the neck, in front of the trachea and the larynx. Don't forget that because later I will discuss a very important aspect regarding surgery. So never forget this. Again, number two, the thyroid gland, as I told you, like any other endocrine gland, is rich in blood supply, no? Highly vascularized. So look at there's a superior thyroid artery and a thyroid vein rich in blood supply, meaning all sorry, endocrine glands are highly vascularized, so rich in blood supply. Never forget that. And the thyroid gland, listen carefully, from the anterior pituitary gland. Listen now, the anterior pituitary gland. You have your thyroid stimulating hormone. Listen carefully. The target is the thyroid gland, and it secretes three hormones. Ready? Your T3, which is called triiodothyronine. Tri because it's T3. Listen carefully. T4 is often called thyroxine hormone with an X. Do not mix nina thyronine with thyroxine X. No? And the hormone calcitonin, which is responsible for calcium. So never forget anterior pituitary gland, anterior, and then the hormone is thyroid stimulating hormone. The target is the thyroid gland. And these are the three hormones secreted. Okay, so let me start now with the disorders. Ready? Because these disorders are some of those which you probably have encountered. First, let me introduce hyperthyroidism. By the very name itself, when you say hyperthyroidism, it means an excessive circulating level of T3, T4, or both. So let me go back. Excessive circulating level of T3, T4, or it could be both. See again. And this problem is more common in women. So, this is not a problem so much with the men. And it's an adult problem, meaning the ages affected are usually 30s or 40s, no, in terms of age group. So it's an adult problem. It's not a problem of the children. I always emphasize that, not children and adult, okay? So please keep that in mind. And these are the clinical conditions under a hyperthyroid. Number one, let me introduce Graves' disease, which is an autoimmune problem, and it is marked by an increased production of the thyroid hormone. So, no wonder you have excessive circulating levels of the hormone. So, it's an autoimmune problem that is affecting. Sige, number two, the second, oh, I'm sorry, the precipitating factor is an insufficient iodine supply. I will explain iodine in a while, so please just copy it the way it is, and I'll explain iodine in the next slides that I have. Sige, thank you. Sige, number two clinical condition is what you call your multinodular goiter. So listen, by the very term itself, it's characterized by small autonomous functioning nodules. Oh, look at that. That's why it's called nodular. No, very small nodules. And each nodule, meaning autonomous, each of the nodule secretes the thyroid hormone, which leads to the hyper, no, thyroidism. So listen carefully though, because these nodules may be benign or malignant. These are very tiny nodules. That's why I know of somebody who was diagnosed with, multinodular goiter. She started to cry and cry and cry because, look at me please in the screen, because these doctors will treat it like it's malignant, because you cannot choose which nodule. Ining a nodule, there are too many of them, multinodular. So, doctors will probably treat you like a malignancy case for that matter. Sige, number three clinical condition is what you call exophthalmos with an H, or you can spell it without an H, exophthalmos. Both of these are acceptable. Okay, so both of these are acceptable. So you can spell it with an H or without an H. Already ready. Under hyperthyroidism, this is what you call the picture that most of you have seen. The eyeballs protrude from the orbit. You can see it. That's why I said most of the endocrine problems are seen in the physical appearance. The upper eyelids are retracted so that the eyeballs are forced outward. So if the eyeballs are forced outward, the sclera is visible. However, I'd like to teach you a characteristic stare and protrusion. Stare is tulok, no? All of them have a very, very characteristic, all of them with exophthalmos has a characteristic stare and protrusion like this. So again, we're talking of appearance. Ready? Or look at how the eyeballs are protruding. Or look at me, please, in the screen. How, listen, follow my pointer, please. Follow my pointer. The upper lids are retracted, so that the eyeballs are protruded. No? Retracted and the eyeballs are protruded. Or look at this picture, please. There is such a thing as a characteristic stare and protrusion of the eyes. So this stare and protrusion is definitely common in a person with exophthalmos. Namati kay Miss Chua. Say yes for me if you can unmute yourself for a while.
Yes, Doc.
Yes, Doc.
Okay, okay, okay. This is
Yes,
the
Doc.
characteristic stare. No, the eyeballs are protruded. This is exophthalmos. Again, what is hyper hypothyroidism? Let's go first before I discuss this thoroughly. It's the opposite. There is a decrease in your thyroid hormone secretion. But look, because the thyroid hormone is very important, with a decrease in your thyroid secretion of the hormone, it slows down your metabolic processes. Listen to me, metabolic. That's why endocrine problems are often called metabolic and endocrine disorders because it can affect what you call the body metabolism. And I'll show you that in a while, what it means to have a slow body metabolism. Ready? The clinical conditions under hypothyroid in children, I always emphasize it's called cretinism. In our local language, a hypothyroid person or even child, listen carefully, child, can be judged as somebody who is retarded. I'm not saying a bad word. Could be judged as somebody who could be retarded, or listen carefully, a very slow mental process, very slow mental process. Now, because the community or the society look at them as retarded or even slow mental process, listen carefully, some people may call them buang. No, they are not mentally disturbed. They are not maladaptive patterns of behavior. They are an endocrine problem. Given a chance and a money, they could have been, diagnosed properly. It's the thyroid hormone which is responsible. Naintindihan si Miss, yes or no, ha? Hindi ni sila ha mental disorder. It's just that they're literally considered to be very slow in terms of mental capacity, no? So I think I heard somebody even saying, I'm sorry, I put it in close quotation marks, somebody even saying, Mambalka, pobre espiritu, no? Pobre espiritu. But these are how people judge who do not understand the hypothyroid condition. In adults, it's called mixed edema, and I'll explain that in a while what it means to have mixed edema. Okay, ready now? Ready? I'd like you to make two. This is the picture of mixed edema. So can you imagine edema, edema? So you have moon face. Listen carefully, moon face. The eyelids are puffy, puffy. Ang ngalan sini puffy, ha? Puffy. Well, kanina ya, ang eyelids ga-retract. No? Kag ang eyeballs na protrude. Siya ya, puffy. Puffy ang eyelids, oh. Puffy ang eyelids. And then there is so much what you call a facial, no? Moon-faced. So a typical picture of mixed edema. Let's go now to assessment. Can you make two columns in your notebook, please, like this? The first column, you write hyperthyroid. The second column, you put hypothyroid. Now, am teaching you when you study, listen carefully, when you study, you put it side by side. So you can study them both, and it's easy for you to recall. It's easy for you to understand. No, hapus ma-understand, hapus man mag-study. So we'll go ahead and, look at the two columns. Sige, let me know. Oh, Sophia and Stephanie has good connectivity. So you can open up for me. Where is usually Dawn has good connectivity. Also Yvette. Yvette, you're very busy, Yvette. No, Kay also has good connectivity. So ready, ready. When we talk of body metabolism, ready? The first that will be affected will be the musculoskeletal. Remember again, sulitin ko, when we talk of body metabolism, body metabolism, the first that will be affected will be the musculoskeletal. Ready? A hyperthyroid is considered to be having irritability, agitation, or listen carefully, hyperactive movements. You must have used this word so well. Hyper na siya bala, gadalaga na siya bala, hyper. And tremors would be one of those with heavy sweating. But because this person is very hyperactive, very agitated, the person has difficulty sleeping, hindi katulog, no? Kay always doing something, always doing something. So, this person has difficulty having sleep. So that sometimes you call that insomnia. So what I want you to do is to look at me in the screen, and most hyperthyroid patients are to undergo a test. Ano ning a test? Patients who are hyperthyroid will be asked to do hands forward. Oh, please look at me. Please look at me. Hands forward. Mana, oh. And then just by looking at the hand, you're able to see whether the person has tremors, no? Tremors. Or if you don't see tremors, you can use your other hand to touch it underneath. And you can feel whether there are tremors, and you can feel that person, whether that person is highly, no, highly active. Sige. So this is a good test. You can do that. You can stand up and put your hand forward, and we can check whether you do have tremors. Sige. Number two, metabolism or your thyroid hormones can affect the hypothyroid, which is, exercising fatigue. And listen, no, you've always heard of me lethargy. When I describe lethargy, meaning sleeping most of the time, tulog nga tulog lang. While the other one has difficulty sleeping, kay perti ka hyperactive, hindi naman tulog nga tulog lang. Okay, and very slow, clumsy movements. So it's a contrast between hyper and a hypo. No? Next, metabolism will affect the GIT. Listen carefully. In a hyperthyroid, the person has increase in appetite and an increase in peristaltic activity. Listen now, which could be seen or heard in hyperactive bowel sounds. And these hyperactive vowel sounds can cause loose BM, which we often call diarrhea, and could be the direct cause of why the person has weight loss. Can you imagine the contrast? Grabe kumaon, good appetite, eating and eating and eating, but now still having weight loss. So that's what a hyperactive person can do. But in contrast to a hypo, ready? The hypo has poor appetite or decrease in appetite with decrease in peristaltic activity, which can be heard as hypoactive bowel sounds and can lead to dry, hard stools, which we often call constipation. Constipation. But in spite of not eating and having a very poor appetite, look at this, the person continues to have weight gain. So you have a clumsy, slow person sleeping most of the time, gaining weight. And you have somebody who is hyperactive and moving around, cannot sleep but is losing weight. Metabolism. That's what metabolism can do. Now, okay, let me move now. The third is your cardiac muscle. So, listen, there are three types of muscles that I've introduced to you in your fluids and electrolytes. Three types of muscles: musculoskeletal muscle, smooth muscles of the GIT, listen carefully, smooth muscles, and the cardiac muscle. Now, with the cardiac muscle, what can metabolism do? Persons who are hyper can develop palpitations, intolerance to heat, tachycardia, which is an increase no, in heart rate and pulse rate. So, again, I don't have to say the normal. What you probably know is 60 to 80. So anything above 80, 90, 100 is already considered tachycardia, no? Either in pulse rate or in heart rate, both. Now, what is in danger of a hyperthyroid is an increase in BP, which can lead to a cardiac arrest. Let's contrast that with a hypo. This time, the hypo has very slow, thready pulse. No? Those thread ba nga kanipis-nipis ang iyang slowness, very, very slow. They are intolerant to cold, so the tendency is they just lie down and sleep and sleep. Wow, tulog na tulog, lethargic kayo. But that has a direct effect on your pulse rate and cardiac rate or heart rate, which we call bradycardia. If the normal is below 60 to 80, below 60 is Brady, and that we should be very careful because the BP can go low and can lead the person to cardiac arrest. So listen to me now. Look at me in the screen, please. Listen. If you're a hyper, your heart starts to beat fast. But be careful because if it's too tacky and the heartbeat is too fast, your client can go into an arrest. But if your heart rate is too slow, very, very slow, very, very slow, and you're bradycardic, your BP is too slow, too low, your heart can go into an arrest. So listen, I've told you this in fluids and electrolytes in potassium. Potassium, listen carefully in potassium. Either way, whether it's a hyper or a hypo, is potentially dangerous to the cardiac muscle. Now, in a hyperthyroid condition, this is often called a hyperthyroid crisis or what you call a thyroid storm. Wow, gabagyo, no? Very high levels, excessive levels of your thyroid hormone. That's why it's called thyrotoxicosis. Toxic levels, very high levels of your thyroid hormone. In a hypothyroidism, it's called mixed edema coma. And I always keep on telling you check the LOC, the level of consciousness. Kay lethargy, sleeping and sleeping and sleeping. The next time you know the person does not respond to both verbal and painful stimuli, nagakoma na. You know, we have a graduate, a College of Nursing graduate. She is class 89. No? And then she messaged me one time in my, messenger and told me, Miss, I just recovered from mixed edema coma. Huh? Ay, kakulubaan sa imo? Ano natabo? Miss, I was just sleeping and sleeping, and my good enough that my children bothered and is not comfortable with me sleeping and sleeping. She was brought to the emergency room just in time for her to really be caught up with a mixed edema coma. So let's be careful with this too. Sige, should we rely on this, Miss Chua? No. Ready? Let me now go to diagnostic assessment. Okay, ready? How can we diagnose the thyroid disorders? First, I'll teach you there is such a thing as a thyroid panel, meaning you can get a blood test of your serum T3, T4, and your TH level, TSH level. Is this in the Philippines, Michua? Yes. I think almost all laboratories is equipped to do a thyroid panel. But I have to tell you, it's a little expensive. Remember what I said? There's a cost related. Now, I think the thyroid panel will cost you almost about 4,000 to 5,000, depending on the laboratory. So if you are that person that doesn't just bother, what you're having through, sometimes we missed the really culprit, which is the hormone. Second, let me introduce a radioactive iodine uptake, popularly called RAI. Radioactive iodine uptake. Now, this is where I will discuss iodine. So, are you ready? Please put it down in your notes now. Ready? Okay, ready. Put this down. Iodine is necessary for thyroid hormone production. So, yeah, write that down. Very important. Iodine is necessary, necessary for thyroid hormone production. Necessary for thyroid hormone production. And I will repeat it. Iodine is necessary for thyroid hormone production. Amo na siya ka-important. So, question. So, I'm looking at you now. Be ready to answer the question. What are our dietary sources of iodine? Where do we get iodine in our diet? Because you already finished your nutrition. Can somebody answer me that? Rain, probably Rain and Maureen Ong. Trisha, Maureen. What are our dietary sources of iodine? Because it's very necessary for thyroid hormone production. Go, Maureen, go.
Fish, miss.
Oh, Rain says fish. What about you, Maureen?
Eggs, miss.
Oh, okay. Can somebody else help out? What is the dietary sources, the primary source of iodine in our diet, in the Filipino diet? Can somebody answer me that? Alphonse, Marian, Angela?
Seashells, miss.
Okay,
Land.
Seashells, miss, are seafoods.
very good, very good. Sige, ready, put it down. Dietary source of iodine, ready? Ay, sa Ilonggo, in Ilonggo, I'll put it in Ilonggo, mga pakinhason ug mga hilamon sa dagat. Okay, let me repeat. Mga pakinhason kag hilamon sa dagat. In English, you call that your seashells and your seaweeds. No to fish because fish is protein. And fish, although everybody call it seafood, but literally it's a very, very low source of iodine. Claro, claro, huh? Everybody give me a thumbs up, please, if you're listening. Where do we get iodine from our diet? Thank you. Now, the third diagnostic test, let me introduce a thyroid scan, or what you call a thyroid scintigraphy. Okay, when you say graphy, listen now, graphy is an injection of a dye to visualize, to visualize the blood vessels that supply the thyroid hormone. I'm sorry, gland. No? So that's why I keep on repeating rich in blood supply because you can do a scintigraphy. You can inject a dye, and that dye will allow you to visualize the blood vessels that supply the thyroid gland. What is that called? It's called a thyroid scan, or you call it a thyroid scintigraphy. Okay, Ready? How do we manage this just before the break? Okay. Oh, I'm sorry. These are the contrast of the two pictures again. You have a hyper with weight loss, laba ang liog no, laba ang liog, and the eyeballs are protruded. And with your hypo, you have a moon face with puffy eyelids, no? So with weight gain. So I told you how important it is to the visual assessment of your endocrine disorders. Okay, so never forget the face. Immediately upon looking, you're able to detect already the disorder. Sige. But ready now, let's go to management. The other side is hyper, the other side is hypo. So ready. In a hyperthyroid, first is we do drug therapy, and we have medications called anti-thyroid drugs or medications, and they are available in the market, and I have to tell you they are pretty affordable. So we will not wait until you have so much exophthalmos na grabe na gid ang exophthalmos, no, because there are such a thing as an anti-thyroid already. Go read with me, go in silence. Propyl thiouracil. Okay, will you please read it with me? Propyl thiouracil, popularly called your PTU. And you have your methimazole, whose commercial name is tapazole. So, it being an anti-thyroid, listen carefully. What's the action of these medications? It blocks the synthesis of your thyroid hormone. It blocks the synthesis of your thyroid hormone. Okay. Letter B. Now, this is what you call very important ang iodine, because the person with a hyperthyroid may be given a radioactive I-131 therapy or iodine 131. In the chemical table, your iodine is number 131. It's radioactive. But actually, listen carefully, your radioactive I-131 is a very big capsule that is taken oral. However, listen carefully. What principle do we observe if clients are on radioactive therapy? Do you still remember that? What are the three principles to observe when clients are under radioactive therapy? Can I listen to you, Robert, if you're there, if you still remember? Uy, na-absent na si Robert. Sige, Patricia Ann, are you still there, Patricia Ann? Absent man, absent ni ko karon. Nicole Villaera, if you're there, absent man. Ay, abaw.
Time. Miss.
Oh, as in una. So you better respond within 5 seconds. Ready? What are the three principles? Ready? That you will observe if the client is on radioactive therapy. I think I also
Time,
discussed.
miss. Time, distance, shielding. Wait.
Okay, who is this?
Angela, miss.
Angela Medina or Baloco.
Baloco, miss.
Thank you, Angela. Thank you. Your TDS. So, because it's a radioactive I-131 therapy, this is usually done in the hospital under your lead room. So, because it's radioactive, the person has to be isolated in a lead room because of time, distance, and shielding. And this iodine radioactive therapy is given to destroy your thyroid gland. So hopefully it should decrease your thyroid hormone production. Pwede ka tulog sa kay miss. I have discussed this very thoroughly on thyroid disorders. Please look at me because they are the most common that I have seen in the past years that usually come out in the licensure exam. If you look at the compilation of those exams in the past, they never forget thyroid gland disorder. So please listen carefully. And a thyroidectomy can be done. And I will discuss this after the break. What about a hypothyroid, Ms. Chua? Okay. With a hypothyroid, you can give thyroid hormones. These hormones are usually very affordable. They usually exist in tablet form. No? So nobody should grow up being called a cretin, no, if properly diagnosed, or should grow up with slow mental process, no. Kaya kung na-diagnose lang very well, then we could have people who doesn't have to undergo and be labeled a retard, no, a retard. So ready. You have what you call levothyroxine, which is commercially called Synthroid. You have thyroglobulin, commercially called Proloid, and desiccated thyroid, which is commercially called Cytomel. So these thyroid hormones are pretty affordable, of course, with a doctor's prescription. You can purchase them and you can buy them in a lot of pharmacy. Oh, listen to Miss Chua, please. Can I stop, Anay? Can you please listen and open up for me? Hypothyroid problem. Listen, the hypothyroid problem that I'm talking about over here, listen now, is now being studied in what you call your newborn screening. NBS. Do you still remember that in your maternal and child? There is a law in the Philippines that all newborn, because they will be born in a birthing facility, no, they cannot be born in the home, they have to be in a birthing facility. All newborns should be subjected to screening. And the number one, listen, the number one that is usually detected is hypothyroidism in the newborns. So that's why I've said these children will have to grow with taking the thyroid hormone. And I know of one child, no, because of newborn screening, one or two, no, duhabla mo, I know of two who grow up. They are now like 8 years old. The other one is 13, who had newborn screening and was diagnosed to have hypothyroid and will be taking thyroid hormones for life. No, for life, because they are detected. So listen, no, and the OH, our Department of Health, has programs that are called newborn screening to detect these problems. Second, DOH is endorsing the use of iodized salt. Yeah, wala siya. Yay. So nowadays, tell your mama and your manang in the house to not just buy any salt. It's got to be iodized salt because iodine is necessary for the thyroid hormone production. I understood. Say yes or no to me, please. Say yes if you're there. Give a
Yes,
thumbs up.
yes, miss.
Okay, so you
Yes.
never forget that. I'll give you 2 to 3 minutes to just, rest your back and stand up and, get your food, whatever. And I'll be back in about 2 to 3 minutes to continue the surgery, thyroidectomy. Okay. So go ahead and do 2 to 3 minutes CR time. Okay, I'm back. If some of you are done with your personal needs, okay, I'm back now. If you can come back, please. Okay, I'm back. Thank you. Let me know if you're back. Give me a thumbs up, Jareel. You've been quiet, Jareel. I'm not sure if you're there, Jareel. You're not responding at all. Patricia Ann also, Guansha, ever since has not had responded. So I'm monitoring. Remember your thumbs up. Laika and Pauline. Pauline, you used to have good connection. So out si Pauline. Okay. Also, Clarissa, you used to have good connection, Clarissa. You're not opening up anymore. Also, Dawn. Okay. Ready. Let me read another message. Oh, okay. Okay. Ready. Okay, ready. The last item here that I discuss with you is thyroidectomy. So this is usually one of the areas of nurse competencies, non-nurse competency that is often asked in the licensure exams. No, nurse competencies asked in the licensure exam. Is Alfonso here? Alfonso, you said you have low connectivity. Just look at the slides if you wish to copy. Now look at the slides. Sige, okay. Now let me discuss thyroidectomy. Ready? Now, thyroidectomy, by the very name itself, when you say ectomy means removal of your thyroid gland. Ectomy, the suffix ectomy is removal. So it could be total removal, meaning complete removal of the thyroid gland, or it could be partial removal of the thyroid gland. So remember, the thyroid gland has a left lobe. So look at me, please. No, left lobe over here in the screen, and it's got a right lobe connected by what you call a narrow isthmus. So a term in India, isthmus. ISTHMUS. So that if you have thyroidectomy, the doctor would either do a partial left, it's got to be specified, kunang left, or a partial right. So it has to be that manner. No, you have to. Okay. Now, what is in this surgery that nurses' aptitude or competence is being asked? Okay, ready. Pre-op. Number one, a client for thyroid surgery has to have complete cardiac status review. It's not enough to have, let me plug an it's not enough to just do EKG. You know, these people with thyroid disorders have to undergo either a cardiac isoenzymes, which is a blood test and very expensive. At the same time, a 24-hour Holter monitor, meaning in 24 hours, your pulse rate and rhythm, okay? Rate and rhythm is being recorded. Why, Miss Chua? Why? O sige, go back into your assessment. Remember what I told you? The cardiac muscle is affected. If it's a hyper, you could have tachycardia, or you could have an increase in BP. If it's a hypo, you could have bradycardia. So the number one requirement pre-op, if you're the nurse, listen carefully, if you're the nurse, check if the client has a complete cardiac status review, especially that most of you want to become OR nurses. This is your job. Part of your OR checklist is to check whether you have a cardiac status review in a thyroid surgery. Number two, the client is usually given an anti-thyroid medication. Like probably the doctor recommends about 5 to 7 days prior to surgery. And you know the action of the anti-thyroid. So look at your previous notes. An anti-thyroid blocks the synthesis or production of your thyroid hormone. Last but not the least, pre-op clients are administered what we call an iodine prep. Here comes the word iodine again. This is popularly called Lugol's solution. So it's a solution, no, that the doctor will recommend. So what is it, Miss Chua? Listen carefully, and I shall be asking some of you now in a while. The Lugol solution is given to reduce the vascularity and the of the gland. So DJ Evan, open up for me, please, DJ, and tell me why in surgery of a thyroid do we have to reduce the size and the vascularity of the gland, and we have to give iodine prep or Lugol solution prior to surgery. Sige, DJ, go.
Uh,
The keyword is there, reduce the size and the vascularity. Can somebody help DJ, please? Why do we want the thyroid gland to be reduced in size and less vascular, less reduce the vascularity? Can somebody answer that for me or any idea, Stephanie?
To prevent shock, miss.
To prevent shock. Okay. Lesser than shock. If somebody can answer that for me.
To decrease blood loss, miss, during
Thank
operation.
you. Thank you. Who is that?
That's Genoxin, miss. Hey.
Okay, says Jen, I know you're listening. Very good. So get ready because we want to prevent hemorrhage during the surgery. We don't want blood loss. We don't want a bloody operation. And why? Because Miss Chua keeps on telling that all endocrine glands are highly vascularized. So, in order to prevent a lot of bleeding and blood loss, the client pre-op is usually given Lugol's solution. Sige, post-op. What are we supposed to do? Number one, Miss Chua will tell you, check the dressing behind the neck. So please look at Miss Chua now on the screen. Please look at me in the camera. Why is you know very well that the thyroid gland is located in the anterior portion of the neck. But Miss Chua said, check the dressing behind the neck. Behind the neck. Sige, question number one. Now I know you can answer this, DJ. What is the post-op position after surgery? Oh, after surgery. Ready?
supine, miss.
Supine or flat on bed? No, I always want to say flat on bed. Okay, everybody, please look at me in the screen and the camera, flat on bed. So Miss Chua says, check the dressing behind the neck. Can somebody give me an explanation for that? Why did Miss Chua don't check on there? Basin bala ka mo dressing dry and intact. But why did Miss Chua say post op? Check the dressing behind. Can somebody give me a logical explanation for that? Neb, go Neb.
Um, but it because Miss, there's a possibility of leakage that
Okay, okay, yes, that's good. Again, listen now, because if there's any drainage or any blood that will come out from the dressing, listen, By gravity, because your patient is flat on bed, by gravity, listen now, it usually flows to the back. Klaro? Uy, pamati nurses ha, kay basi malakadlawan kita, people will laugh. Kagabalo nga, where are you a college graduate from? You don't know. This is a thyroid surgery. Don't look at the front. Look at the back. Because if there's any form of drainage by gravity and you're flat in bed, it goes to the back. Okay, number two, we're supposed to observe for respiratory distress. Now listen good. In our anatomy, I emphasized that our thyroid gland is located in front of the trachea, and the trachea is alagyan sa hangin. Maybe due to trauma, edema, or hemorrhage, the trachea is affected. So, listen, it's an emergency thing to do. At the bedside, we should already have a setup of oxygen, complete setup. At the bedside, prepare your suction machine. Do not keep on running and running and running. Suction machine, that's your responsibility. Huh? Ang damon nyo na daan ng oxygen kag suction. Kag the last thing, in cases of respiratory distress, a tracheostomy set and an emergency tracheostomy will be done on the patient. So that's really bad because we very well know that probably your trachea has been traumatized or that the patient cannot breathe very well. So that's why this is a favorite in terms of nursing competency that comes out in the licensure exam. Number three, Miss Chua will fill the page. Listen, arapalanta sa half the page. We will observe for signs of tetany. And what are the signs of tetany? If your patient post-op will exhibit spasms or tremors, tics, or even the worst is seizure. Spasms, tremors, you get to have a patient with a hand that's trembling, tics probably, and seizure. So question, why Miss Chua? Why? Ready, ready. Why? Ready. This is the thyroid gland. Look at me, please. I'm now explaining the rationale. At the back of each thyroid lobe, right here, are two oval structures which are called your parathyroid glands. This is the back. Listen, at the back of each thyroid gland are two oval structures, oval o araw, in each lobe, which are called your parathyroid glands. That's why there's always an S. Okay, there's four of them. Oh, listen, it secretes the hormone, parathyroid hormone, or what you call your PTH, which is responsible, listen now, for calcium. And you heard that from me in my introduction. This is what you call your complex feedback mechanism. No, it so PTH is there. So listen now, pamatigid. If thyroidectomy is done, thyroidectomy, it is possible that your thyroid glands will also be removed. Okay, let's go back. What is tetany? Tetany is similar or equivalent to the word hypocalcemia. Write it down, please. And that will definitely be out in the licensure exam. Hypocalcemia, because of the removal of your parathyroid glands. Okay, so what are we supposed to do in emergency? If you notice, I put it in yellow. No, so that means it's a very important thing. Patients in emergency cases are given calcium gluconate, and they're usually given IVTT, When you say two Bex has to be prepared at the bedside, meaning it's a prepackaged syringe like this. When it's prepackaged, meaning in cases of emergency, the nurse simply have to remove the needle cover and you can give it IVTT to the patient. Why? Because of calcium deficiency, hypocalcemia. Na, grabe. Okay, next. Wow, Miss Joa. Sige. We will observe post-op for a thyroid storm. And the thyroid storm usually presents itself with an increase in body temperature, an increase in pulse rate, and an increase in BP. Oh my God, no increase BP. Taas BP post-op. Sige. So that as a nurse, knowing that you have a client with thyroid surgery, we're supposed to prepare an anti-hypertensive medication at the bedside. All of these are at the bedside in cases these will happen post-op. And for increased body temperature, we have a cooling blanket, to cool down the entire body. But let me tell you about your antihypertensive medication. Ready? I have a very bad experience with this. The usual antihypertensive medication, can you please write it in your notebook, is usually a calcium blocker. Usually a calcium blocker is, prepared. Why a calcium blocker? Okay, listen, this is what happened to me and my our student nurse many years ago. Okay, we have somebody with a thyroid surgery whose blood pressure was like 180 over 100. So the doctor said, who's the nurse here? And then, there was a student nurse. So the doctor said, okay, give this medication and gave it to the student nurse sublingual. And so the student nurse followed very well and put the medication sublingual under the tongue like this. Open up for me. Open palihog. Open gid. Open gid. Open palihog sa kay Miss Chua. I'll put it in a different view so all of you will see me. Okay. Okay, ready? Oh, okay. Ay, hindi na kuman. I'm supposed to have the speaker's view. Why am I not seen? Ah, sige, okay na. Eh, di na. O si Neb, Neb. Dapat ako da, Neb. Why are you there?
Naka-speaker's view ka na, miss. Basi
Ah,
na pin mo lang siya. Pero ikaw, di ka gwa sa amon.
oh, really?
Yes,
Oh,
miss.
okay. Sige, do that again. Thank you. Thank you. Sige, okay, ready? Di na ko. Where am I? Ah, okay, ready? Nano man eh. Can you get out from yourself there? Sige, okay, ready. I need to have a gallery view. Sige, ready. This is the appearance. I don't know if you can see it very well. This is the appearance of what you call your calcium blocker, which is popularly called Adalat. It looks like this. Sige, it's a soft gel, no? And it is given sublingual. Oh, listen carefully, ha? Look at me carefully. Amo ni siyang itsura. So it looks like this. Now, I had the shock of my life. Now, after 3 minutes, when we get back to the patient, the blood pressure was still 180. So I said to the patient, were you given the medication? Nakabaton ka bulong. And the patient started to say, and started to point. Then I said, okay, using a tissue paper, I asked the person to spit this gel like structure. And then I told the student nurse with the use of tissue like this, I'd like you to get a needle, a clean needle, and prick number of times your your soft gel, prick it many times, and squeeze the content under the tongue like this. Squeeze all of it. Squeeze it. No, squeeze all of the contents because your tongue is very rich in blood supply, and this will definitely lower the blood pressure. True enough, after 3 minutes, the blood pressure started to go down and go down. So that's why people will probably call me, or my students call me very strict. And I always tell them, do not do anything without me knowing it. Because I don't want to commit error. Ginakadlawan kita, no? Hindi kabalo aton student nurse because it means the doctor said sublingual. Oo, sublingual, but you don't know nga with this type of medication that you are supposed to give is a soft gel, then prick it with a clean needle and squeeze the content, all of that under the tongue. Okay? So it will definitely work wonder and lower down the blood pressure in cases of what we call, we have what we call thyroid storm. Sige. Next, wow, kadamo Miss Chua, uso rigid. Because in a thyroid surgery, we're supposed to relieve the discomfort of a sore throat so that we should encourage our patient to have oral fluids. Ang term kasi ni sips of water. So using a straw, sip. Tip miss, nag-surgery. Oh, look at your anatomy. Where does the water go? It goes to your esophagus and GIT. But your surgery has nothing to do with your esophagus. Okay, and probably if we could have been in a advanced setup, we can have a cool mist humidifier inside the room to prevent dryness of your air, or your moisture is added to your room air. Oh, next, we're supposed to check for a voice. Okay, ready. Post up immediately upon receiving the patient. If the patient is conscious already, you have to ask them, tell me your name. Tell me your name. And the patient will just simply say, and you start to say, hindi ko mabatian, pwede, sugad jutay. What's your name, sir? Sino gani ngalan mo, sir? And the patient starts to say, sorry, what are you supposed to do? Report it immediately to the surgeon because that signals what you call laryngeal nerve damage. So your patient has difficulty making a voice. And that's why very important kay Miss Chua, you understood the anatomy, no, of that. So we used to have a faculty in the College of Nursing who had to undergo thyroidectomy. She has to stop being a clinical instructor because her voice was so harsh. And she started to say, class, class, even with a microphone. Class, are you listening to me? Are you listening to me, class? Obviously, there was laryngeal nerve damage. So I understood nurses. So, do we understand now the complexity of a thyroid surgery? Say yes or no to me, please. Say yes or open up and say yes.
Yes.
Okay, thank
Yes,
you.
Doc.
Sige. Give me a thumbs up or a heart or a boom if you're there and awake. If you're awake, ooh, tulugan na yan. Tulugan niya si Pauline. Oh, ara dahil si Pauline. Sige, Aliyah, oh, natulugan hasta si Denise. Sige, okay, ready. That should close my discussion on thyroidectomy unless you have questions. Let me proceed now to the number three thyroid disorder I will discuss very briefly is called simple goiter. This is not hyperthyroid. It's not hypothyroid. It's simply called goiter. So what is it? The simple goiter, ready, is simply an enlargement of the thyroid gland. It's not inflammation, it's not infection, it's not neoplasm or cancer. It's not. It's simply an enlargement, no, of the thyroid gland. Then it could be endemic in nature. It could be an endemic type of goiter wherein people could suffer from a nutritional iodine deficiency, and that's how important iodine is to the thyroid gland. Or it could be called sporadic type of goiter, wherein it's caused by the ingestion of very large amounts. Let me now introduce goitrogenic agents. We have pagkaon, food. We have food that are considered goitrogenic. Like, for example, cabbage is one of them, like peanuts is one of them, like you say peas is one of them, soybeans, no, mga peas, strawberry even, ayun na lang, wala ta strawberry, no, spinach, or even radish. So if Popeye were real, Popeye, then he could have had goiter. Kaya nga no, to give strength to Popeye is he eats a can of spinach. Sige. Okay, let me interact with you and ask you question. Sige, Sab, are you there, Sab? Let me ask you.
Yes, Doc.
Okay, ready and Dawn. Sige, which type of goiter would be present for those people living in the coastal area, meaning higad sa baybay, or which type of goiter would be present for those living in the mountain area? So can you analyze that carefully, Dawn? And I will go to you, Sab, in a while. Which type will be, part of that goiter thing? Sige, can you give me an answer now? Go, Dawn.
Means endemic means in coastal area, and then sporadic mountain area means.
Oh, okay. Nga naman nga sa coastal endemic.
Because of the iodine, mis nga ang mga people mis nga gastay sa mga coastal area, gait mga seaweeds.
Okay, very good. Thank you. Okay, what about you, Sab? Do you think otherwise, Sab?
Yes, Doc.
Sige, go.
Um, but however, Doc, there are cases man siguro na endemic appears to people living in the mountain areas since deficient ang ila source of iodine, whereas sporadic naman, Doc, in places near the coastal areas since abundant ang iodine sources nila, Doc.
Okay, sige, sige. I will, when you're given that type of question, ready, nurses, let me teach you. It is possible. Now, those living in the coastal will be endemic. Those sa bukid will have sporadic, or it could be the other way around. Na ang ara sa coastal will eat more of these, kay wala ni sa ila, and those in the mountain will suffer from endemic because wala man to sila iodine sources, nga seaweeds, kag seashell. Possible. But if I were to answer your question, ready, listen carefully, nurses, for the board exam. Ready? You have to look at the dietary habits of your patient. You have to get a dietary history and ask them, ano balagid ang imong ginakaon? Ano bala favorite mo? Anong hindi mo ginakaon? Kay because the key to an answer could be in the dietary habits of the patient. I understood, nurses, yes or no?
Yes.
Sige,
Yes,
okay.
Doc.
Sige, let's look at somebody with a thyroid goiter, and it's simple goiter. It's simply an enlargement. Oh, look at this. It's simply an enlargement of the thyroid. And look at the age probably of this patient. And actually, I saw this lady sa Mambukal, no? Many, many years ago, I saw her selling flowers or, kanang mga tanom. And she was wrapping her neck with a lampin. So she said, Ma'am, bakli ko. And I said, sige, baklanti ka. Ah, sabat anay sa akon pabangkot. So I said, sige, first, ano na ni kadugay ang imong goiter? I was amazed at her answer. She said, Ma'am, kana nabughat ko. You must have heard of that, from lay people. They said, Ma'am, nabughat ko. Tapos nagdako na siya, Ma'am, akong liog. Ning ko pila man ni edad nimo nagsugod. Then she said, well, 35 ko, ma'am. Ning ko pila edad mo subong? 65. So this goiter has been there for 30 years. 30 years, huh? So I said, pwede balati ka ma-refer sa Corazon Luxin. Kay may free surgery man sila sa amo ni nga klase. I was amazed at her reply to me. Listen carefully, nurses. Listen to me. What was her reply? Listen carefully. She said, Ma'am, bay ila na da, ma'am. Kay wala man na naga-disturbo sa akong pagginhawa. Wow, I got amazed. Oh, really? Wala man ga disturbo sa akon pagginhawa. And I started to analyze ano man anatomy, no? Anong anatomy? And that's where I get to really appreciate the anatomy. When you say your trachea is lagyan sa hangin, the simple goiter is simply an enlargement. Okay? It's not cancer. It's been there for 30 years. No? And then definitely not an infection because otherwise you would die of septic shock. Nah. So, you have got to listen to these people, why they are keeping this. Yes, I would say she's a candidate for thyroidectomy. It's really big. It's really big. Okay? So intindihan kita. This is another picture of a milder form. It's still starting. I don't know. You have to look at it on the, malayo. Look at it from afar. Look at it from the far aspect and look at the enlargement over here on the left side of the neck. So it's just starting. It is already obvious if you look at it from afar. So it's simple goiter. Let me introduce now thyroiditis, which is number 4, which is called inflammatory process. Again, in the initial infection, purely an inflammatory process wherein the thyroid tissue is replaced by fibrous tissue. Why? Because of stress, because it's an autoimmune process. So, stress can do too many things for the body, especially that the thyroid tissue is replaced by your fibrous tissue. So, it can no longer give you your thyroid hormone. It can no longer secrete and produce your thyroid hormone. Now, this is popularly called Hashimoto's thyroiditis because this disease is very popular on the Japanese male. Mga lalaki and Japanese male, very obsessive to work, work, work. Sige lang work, no? Grabbing mag-work, work. Are always under stress. So that, again, let me repeat, it's simply an inflammation. So, with that inflammation, the tissues become hardened, gatig because of that autoimmune process. So, now let me summarize our disorders. Listen carefully now. Hyperthyroid is an increase in your thyroid hormones. Hypothyroid is a decrease in the thyroid hormone. Simple goiter is just an enlargement. Thyroiditis with the itis, remember I play this with you in II, no, in my first sem. Anything that ends in an itis does not necessarily mean infection. it's purely an inflammation. So, am I clear now with how important your thyroid gland is? Say yes or no.
Yes.
Yes,
Yes.
Miss Doc.
Okay, sige.
Yes.
Let
Yes,
me
Doc.
now go to the number five problem, and I will end up here. NCM, or nursing care management of clients with adrenal cortex disorder. Isa lang ang i-discuss ko, ha? Which is popular and common. So please organize your notes, as I've said. Number one, diabetes. Number two, your anterior pituitary gland disorders, your growth hormone. Number three, you have your posterior pituitary gland, your ADH. Number four, you have your thyroid gland disorders. And number five, you have your adrenal cortex disorder. So let me go now. Let me introduce the adrenal glands. Ready? Location again. I always start with a location. Location. Ready? It's located in the upper pole of each kidney. So if this is your left kidney and your right kidney, upper pole of which is called the adrenal glands. There are two of them. That's why you always call them glands. Okay. Upper pole of each kidney. If you were to do a cross section of your adrenal gland, the outer portion is called the cortex right here. Cortex, which is the bigger portion, which is called 90% of the gland. And then the middle portion is called your medulla, which is the smaller portion, about 10% of the gland. So, and the cortex being the bigger portion, secretes 50 plus hormones. So listen, which I do not expect you to memorize. So these 50 plus hormones are classified into three. Okay, ready, ready? You have your glucocorticoids, which is called your GCC, your mineralocorticoids, which is called your MCC, and your sex hormones. So the 50 plus can be grouped into three. And that's what we call over here your cortex, ready? Your MCC, mineralo, your GCC, which is your gluco, your androgen, which is your sex hormones, and your catecholamines on the inner, no, inner aspect. So you must have heard of your catecholamines, your fight and flight hormones, which is called your epinephrine and your norepinephrine. Where are they located? In the medulla of your adrenal gland. And then if you were to do a fluoroscopy, please look at the screen on top. It's a beautiful, like Hershey's kisses, on top of each kidney. So that's your adrenals. Okay, ready. Let me introduce one disorder which is fairly common, and you call that Cushing's syndrome. Okay, why it's called a syndrome? Ready? It's a spectrum of what you call your clinical abnormalities. And what's the cause? As usual, when I talk of the cause, it's always the hormone. Ready? Caused by an excess of your GCC or your glucocorticoids. Cause is always the hormone. So keep that in mind. Cause is always the hormone, particularly what you call your corticosteroids. Sige. Cushing's is more common in women. Wow, babae naman, no? Just like hyperthyroid. And, ready? Your steroids here has an arrow, meaning particularly corticosteroids, because the cause is called iatrogenic. So please, please S- Speak with me. Iatrogenic. Ralph, do me a favor, Ralph. I know you're techie. Can you Google it, please? And look at the meaning of iatrogenic. Sige, Google it for us. Iatrogenic. Okay, ready? I'm listening, Ralph.
Relating to illness caused by medical examination or treatment.
Thank you. Thank you. Perfect. So listen carefully. What is the cause that you have your excess of your GCC? Listen out. Listen why. What's the cause? Because of a medical treatment. Iatrogenic medical treatment. And what is that treatment? The prolonged use of steroids. Wow. That's why your patient has a spectrum of clinical abnormalities, which you call Cushing's. Sige, let's look at iatrogenic when you say it's treatment, no medical treatment, as what Ralph said. Ready? Let's look at corticosteroid therapy. What are the common names and preparations of corticosteroids? Ready? You will encounter them with the suffix "zone," no? Cortisone, hydrocortisone, dexamethasone, prednisone, betamethasone. So these are the common preparations of what you call your corticosteroids. Ready? Ready. When you say preparation, ready, your corticosteroid could be given oral, meaning tablet form. Please write it down. So it could be given in tablet. So are you writing for me? Oy, sulat palihog. Kaya base madula. Nakita o, nadula na si Joey. Nadula na si DJ, o si Ella, o si Maureen, o si Pauline. Uy, nadula na tanan. Si Ses o si Wella, baw, absinan naman ni naton karon. No? Kay wala ba pabalo o si Jeril o wala gid di ka respond since kanina. Maybe you know what you're doing sometimes you just open it up but you're doing something else, so you be careful. That's why I warned you about academic integrity. So you just keep it open but you're not listening, so be careful. I'm not giving notes anymore. I'm not giving PowerPoint. No, so last night sino ganitong ka-text sa akon, Miss Aliyah o sino? Aliyah was saying, Miss, are you giving PowerPoint? Not anymore. I told you to take down notes. So if you're not present, you are definitely lost. Sige, oral, ready? Oral tablet. Second, common steroid are given injectables. Injectable, meaning liquid, no? Injectable. So pwede ka kahatag steroid by injectables. Sige, number three, very popular is what you call your cream, your lotion, and your ointments. So you have ointments that have steroids on them, lotion, cream. So these are your steroids of them. Number four, these steroids could be given in drops, no? So like mabalka eye drop or ear drop. So drops pwede. And most of all, steroids can be given through inhaler. Inhaler, kanang puff ba, puffs. So steroids are common. You know, they are given in different preparations. And they are, you know, have to be prescribed. Oh, amo palang pagsulod ni Jiril. Oh, sige, go. What are they intended for? What's its therapeutic effect? Its indication? What is it for? Okay, ready. Now, steroids are usually called SAID. SAID. Who remembers me saying SAID? What does a SAID mean? SAID. Oh, Isaiah, what's SAID? SAID.
Steroidal anti-inflammatory drugs. Yes.
Thank you, thank you. Yes, yeah, put off your sound. Kaya hindi ka nakabati karon. Okay, SAID is anti-inflammatory agent. Who is George Emmanuel Villanueva? Who is he? Should I admit him? So tell that person to change the name before I can admit. Okay? Sige. So again, they're popularly called your steroidal anti-inflammatory agents. They could be given for inflammation, allergic reactions, immunoreactive reactions, edematous, skin problems, malignancies, even cancer, degenerative, and even chronic conditions. So, it's like a wonder drug that can treat almost any condition. That's why they are popularly called steroids or your steroidal anti inflammatory drugs because patients will feel better. That's why they're called wonder drugs. Patients feel better. Okay, ready? Let's go through a list of A conditions that starts with the letter A that are prescribed steroids. Sige, look at my screen now, Angela Baloco. What's the first A? What are steroids for? Give me one condition. It's in the screen.
Allergy, miss.
Thank you. List it down, please, everybody. List it down. Allergies. Very good. What's an A that is related to the inflammation that will definitely affect you and your breathing? What is that letter A? Inflammatory process that affects your breathing and you cannot breathe. So, what is that condition called? It starts with the letter A.
Asthma, miss.
Thank you. Very good. Asma, go. Sige, ready ha? Sulat na, tanan nga A. What's that A condition that I discussed with you? It's because of severe allergy. What is that condition that starts with the letter A? And I've discussed that in the past, in the first SEM. Go.
Anaphylactic shock.
Thank you. Anaphylaxis. Very good. What is that A that is common in the elderly for degenerative and chronic conditions wherein, our elderly has difficulty walking and even moving? What is that A condition?
Right.
Arthritis. Wonderful, wonderful arthritis. Now, what is that A skin problem where everybody gets to be too conscious? You have low self-esteem because you have a real bad flare of a skin problem that is seen in the face. It starts with the letter A.
Angioedema.
Acne.
Acne, very good. Acne. Sige. What is that immunoreactive condition that we have discussed in the past that will really need steroids, that will need SAID, an anti-inflammatory agent? It's an immunoreactive condition that starts with the letter A.
AIDS.
AIDS, not really, because AIDS is virus, no, virus and AIDS. So A, immunoreactive, and I know I discussed that in the past. Starts with the letter A. How easily you forget. I discussed that earlier in my slides. Sige na. Immunoreactive condition that starts with the letter A and will depend on steroids for medication. Somebody open up, please. Why get? No, no, no. Starts with the letter A. Joey, if you're listening, Ella, if you're listening, immunoreactive. It starts with the letter A and depends so much on steroids. Along. I will give extra points to those who will. Somebody put me in the chat. Sige, chat room. Oh, no, 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 not anaphylaxis, Hans. No. Sige, go, go. Who can do that for me? Who has a good recall, an immunoreactive? And I discussed this earlier in my slide, previous slide. And I particularly said that, sige na, absinan ko ni karon. Adrian, wala nagapakita si Adrian. Oh. Di wala get. Ate, madugay kita sini. 4 o'clock na. Wala gid wala gid That starts with the letter A, immunoreactive. None of you ever remembered autoimmune problems? Sige. Immunoreactive. A that starts and really depends on steroids for medication and autoimmune problem. Wala gid. Ay, wow. Anyway, sige, let me not just ask na lang para I don't get disappointed. Now, because of use for these medications, no, the steroids, what are its adverse effects? Sige, number one on the list is what you call sodium and water retention. So patients on steroids usually have a picture of edema, no, the moon face, no, they gain weight, their blood pressure gets to be high, or congestive heart failure. Because remember, steroids are given prolonged use. They're not given just for one day. No, you are wrong. Steroids are given on prolonged use, medical treatment. Otherwise, your patient will have real serious problems. So they are on prolonged use. So their picture would be of sodium and water retention. Number two, they can suffer from GIT symptoms, like probably feelings of nausea and vomiting or even gastritis. The worst that can happen is an ulcer, and they are prone to GI bleeding. So that's why it's very important that these steroids have got to be monitored. The third is my concern, endocrine, and this is where Cushing's come in, because an adverse reaction to prolonged corticosteroid therapy is your Cushingoid appearance, which we will discuss in a while. Then you have menstrual irregularities for women. Last but not the least, steroids are very, very dangerous because they give you immunologic response that will increase your susceptibility to infection. On the outside, you feel good, better. But on the inside, be careful. They mask infection. So just like mascara. On the outside, you're smiling, but inside, you already have susceptibility to infection. So persons on steroids easily develop secondary infection and could die from it. I know of somebody who had been on steroid therapy, very, very easily develops pneumonia. So that's why in this COVID time, ever since, she has not been out of the house. Kay Bao, very, very immunologic because she's very, very susceptible to any form of infection. This is the appearance of the clinical abnormalities in Cushing's. Clinical abnormalities found in Cushing's. Sige, we will group all of them. So go with me and go with your notes. Number one, we have what we call Cushing's exhibit, what you call centripetal obesity. Centripetal obesity, meaning CENTRIPETAL, centripetal. Okay, look at me in the speaker's view, please. Centripetal is on the inside. No? Okay, ready. First on the list of centripetal obesity is a moon phase. So I already discussed that, moon phase. Number two is what you call a buffalo hump. On that back part, you see a particular hump. Why it's called buffalo, like Carabao, for example, that's the portion where you will sit down. Okay, this is the good portion where your back doesn't hurt. Number three, let me introduce supraclavicular fat pad. So look at me, please. Amuning clavicle tao. You have supraclavicular fat pad. Fat pad. Okay. Number four, patients with centripetal obesity has what you call a pendulous abdomen. Are you writing, Neb? Neb, are you writing? I'm not giving notes, Neb, huh? Sige. So pendulous abdomen, meaning just like the pendulum of a clock. When the person moves to the other side, that's where your abdomen go. If the person moves to the left side, then that's where your abdomen goes. So it's a pendulous abdomen. So a picture of what you call centripetal obesity, number one. Number two, patients with Cushing's syndrome exhibit what you call protein wasting. Okay, ready? Protein wasting. And included in the protein wasting, ready, are thin extremities with muscle atrophy. Can you imagine the picture? No? You have centripetal obesity, and then you have very thin extremities, no? With muscle atrophy. Second, number two, you have a thin skin and subcutaneous tissue. So very thin skin with subcutaneous tissue. So very obvious a protein wasting, no? And then number three, you have slow wound healing if in case you have a wound. Number four, the person in is subjected to ecchymosis or hematoma resulting from easy bruising. So yan no, maigo lang pala due time, ma-bruise na, no? So this is a result of protein wasting. Number two picture is protein wasting. Okay, you have your ecchymosis resulting from easy bruising. Number three group of symptoms. Okay, the third group of symptoms may or may not have. So pwede man pwede, may ara, pwede wala in Cushing's. Okay, may or may not have. Number one, thinning of hair. So may or may not have thinning of hair. Sige, number two, may or may not have acne. So may, pwede man, may not have, pwede man. Number three, red cheeks. No, red cheeks may or may not have, especially in Cushing's. Actually, some I saw with red cheeks, but most of the time, the persons that I saw with Cushing's have very pale skin. Sige, number four, may or may not have, ready, increased body and facial hair. Increased body or facial hair. So may or may not have, where they increase body and facial hair. Next, may or may not have what you call purple stria. So listen carefully, in the abdomen, you can see the stria, no? They're usually purple in color. Oh, listen now, pamatigid. Because of the thin extremities, look at Miss Chua, please, in the screen. Look at me. Your purple stria can also be seen in the arms right here because thin extremities. Ari, ah. So, ay stria manidi. Okay, because of the protein wasting, listen carefully. The back of your thigh right here can also have stria. So it's not a beautiful picture. I'm really sorry. That's why we call it a clinical abnormalities, different pictures. So can I am sorry. I forgot weight gain. Weight gain should be in number one, centripetal obesity. Okay, so ready? So the Cushing syndrome abnormalities can be grouped into three. Ready? Centripetal obesity, two, you have protein wasting. Number three, may or may not have the symptoms. So please, ready, pwede ka tulog kay miss. I ask of you, if you see somebody with Cushing's, please have the attitude of acceptance, non-judgmental. They do not like to look like that. But because iatrogenic, listen, because iatrogenic, because of medical treatment, pamati, receiving steroids, now this is what you call an adverse reaction. So again, pwede no, katulog kay miss, so let's say you have two sides of a coin. You have to give the medication, the steroids, because the steroid will help the patient, treat the patient. But at the same time, where you're giving steroids, look at my hand, please. Look at my hand. You will have an adverse effect, particularly Cushing's. So you have to weigh, you know, we have to weigh pro and con, because what is the choice, Miss Chua? Sige, there is always an alternative management to manage persons on steroids. What is that? Listen, there's only gradual discontinuance. Listen carefully, please. Listen, this is a board exam question. You do not stop steroids immediately. No, no, no. Steroids, no, it cannot be stopped abruptly. Otherwise, your patients will suffer from crisis. No, crisis, and the crisis could be very dangerous. Like for example, if it's asthma, pamatigid, if it's asthma, ma-crisis na sa asthma, ay ambot, mapatay na. No? Kahit di asthmatic, hindi ka ginhawa. So it's only gradual discontinuance. Or it could be reduction of your steroid dose until the steroid dose gets to be very, very minimal. And what you call conversion to an alternate day regimen by giving steroids, MWF, or TTS, no, alternate day, but never to stop, or probably miss no steroids on a Sunday, kay MWF lang or TTS. So again, let me repeat, corticosteroid therapy can be managed by alternative measures, no, alternative measures. So, but in spite of that, listen, this is not a cure, no, because the person still will continue taking steroids, especially the PAFNA, no, look at me, PAFNA, no, that they have for asthma. You could be on puffs for a longer period of time. So you cannot detach yourself. So it could be just a reduced steroid dose for that matter. So let me end up and wrap up your nursing diagnosis with endocrine problems. And I'd like to emphasize the priority. Endocrine problems affect the physical appearance of the person. So the person will have body image disturbance, or what you call altered self concept, or a very low self esteem because of the endocrine problem that person is suffering. It affects, especially in today's world, everybody's conscious of appearance. Okay. Second, they are very high risk for infection. And I did not just say actual or potential, but I said high risk gidya for infection, because a lot of endocrine problems affect what you call your body metabolism. Next, you could have activity intolerance in a lot of your patients who would just be sleeping or either hyperactive. But never forget, they have to have appropriate nutrition. So they still have to eat. They still have to have appropriate dietary sources. Then, never forget that in diabetes, you have sensory and perceptual alterations. with your three-piece, no? Mga paresthesia, mga pain, mga partial loss of sensation. So you could have sensory perceptual. You could have spasms. You could have tremors. You have to put there your sensory perceptual alteration. Never forget the favorite of Miss Chua, your fluid and electrolyte imbalance. So I am doing brainstorming. If hindi ka balo mag-answer, palihog ibutang na lang fluids and electrolytes. Okay, with edema and dehydration, with a urine output that is either scanty or polyuria. So fluid and electrolytes are very important. But again, your patients could be high risk for injury. Now, how are you going to do this, Ms. Chua, in the midterms? And even in the licensure exam, I usually give this in, a situation, and I will ask you to identify the appropriate diagnosis. Okay, so it's up to you to find out the appropriate diagnosis. This is now what I told you. It's not a beautiful picture, but I need you to accept the person and to be non judgmental. So everything has to come from the nurse. Thank you. Are you a better nurse now? O sige, clap to yourself. Clap, yeah. Miss Chua, natapos man gid. Okay, ready? These are the announcements that I will do. Bosi, Isaiah, wow, 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 gamugid sa Isaiah. Okay, ready. Announcement number one is tonight, I will be posting in your canvas an assignment which I'd like you to accomplish relating endo. And the answers are all in your notebook. So no excuse for not getting perfect, huh? Sige. I will give a deadline, not too soon, but still far. So I will just give a GC notice to our officers so that you can open your canvas. Number two, listen now. Tomorrow, because I'm done, you will have Miss Murphy to continue with your GIT concept so that you can finish it ready for midterm. Unless you have questions, I think I would say that's it. When will I see you again, Miss Chua? Kay preparahan giti ka. Okay. I don't know. I'll depend on Miss Murphy when I will come in, but definitely it will be included for end terms. Okay. I'll come in with musculoskeletal disorder or your ortho. And then we have divided the neurology concept with Miss Murphy and me. But Miss Murphy still has to finish the EENT concept. Okay? O smile man. Do wala gi kami yung smile na. Do may masala pa ko sa inyo wala. Do wala damo pagi ko sa law. Sige, attendance na eh. Attendance na eh if you're there, be. I'm not even sure if you're there, no. Sige, tawagan na si tawagan na, tawagan na. Tawagan na, text message na. Uy, hala, check na si Miss Chua, attendance. Sige. Okay. Tawagan na si Don ay. Okay. Tawagan na si Katrina ay. Wala ni pulo pakita si Katrina ay. Si Jeril, ari na si Jeril. Hala, sinantagin ni karon si Valerie, no? Nabudlayan si Valerie o come in. Okay, I know about John Espera. Damo ni kwarta John Pro. Drive ganini yan sa lakyan. Damo ni load dyan. Ablihin ang imuhang Hindi ko magpati nga wala ka kwarta. No, naga-drive ikaw sa imo So, sinanta ni si John karon. Okay. Say thank you and goodbye now.
Thank you and goodbye, Doc.
Thank you,
Ay,
Miss
ari
Thank
naman
you.
kita
Goodbye,
kita.
Thank you and
Kita ko
goodbye,
Goodbye,
Doc.
kita ko
Miss.
naman gid si Jan, oh. Ay, si Jan. Nagahapo-hapo si Jan. Nagahapo-hapo si Jan kay kadalagan. Okay. Say, leave Jesus in our hearts.
Forever.
Okay,
Ever.
smile everybody because you're taking pictures. Sige, smile everybody. So I'll see you. Bye. Say bye now.
Bye,
Nag-smile man
Doc.
sila.
Bye,
Ito.
Thank you,
Okay,
Doc.
sige. Thank you.
Bye, Doc. Thank you.
Okay,
Bye, Doc.
see
Thank
you.
you.
Bye, Doc.
Okay,
Bye,
Thank
Doc.
you.
bye-bye.
Thank you.